Good evening, ladies and gentlemen, colleagues, organizing committee of Dubai Pediatric Club. I would like to welcome all viewers from Dubai, UAE, all GCC countries, and all countries across the globe, especially from India. Tonight we will have many viewers from India. Well, this webinar entitled Is a Zero Antibiotic NICU Possible? We have eminent speaker and panelists and team of moderators. In a short part, I'll be introducing them. This webinar is conducted in collaboration with NMC Specialty Hospital Dubai and is sponsored by Vita Biotics UAE. I would like to thank the country business manager of this company, Dr. Tawfiq Ali, who is always helping us. Well, always I start with the beautiful Dubai, the most beautiful city in the world, the best time to come and visit, good climates. So all are welcome. But as usual, there is a question. Who is this doctor? The first person who answered right, we announce the name and Dr. Tawfiq will give a token of appreciation. Well, as I said, today's session is neonatology. The topic is a zero antibiotic NICU possible? Our speaker is very well known to all of you, Dr. Monica Koshal, Senior Consultant Neonatologist at Emirates Specialty Hospital, Dubai. She is the director of that hospital and very well known neonatologist, not only in the UAE, but in Asia, India, and beyond. We have a team of eminent panelists, the senior most Dr. Javed Abibullah, consultant neonatologist at Kilimanjaro Medical Center, Dubai, and Dr. Jayoti Talukdar, specialist microbiologist, infection control, and antimicrobial stewardship expert from NMC Specialty Hospital, Dubai. I'll be chairing the session, and our moderators, very well known to all of you, Dr. Kalpana Singh Gupta, Senior Consultant Pediatrician and Head of Department and Secretary of the club, very well known to you, and Dr. Diari Muhammad, Senior Consultant Pediatric Surgeon at Al Jazeera Children's Hospital and the Chairman of the Academic Affairs. Well, on behalf of all my colleagues in Dubai, members of Dubai Pediatric Club and the members of organizing committee, once again, I would like to welcome all of you in the organizing committee, myself, Dr. Joshi, past President, Dr. Kalpana Sen Gupta, Secretary, Dr. Diari Muhammad, Chairman of Academic Affairs, Dr. Muhammad Amir Toleimat, Dr. Ayman Jundi, Dr. Rafia Obera, Dr. Srinivas Bandari, Dr. Leila Albari, and Dr. Khalid Rashid. Well, about future DPC events, the most important are 11th annual DPC conference will be held on 17th, 18th May, means Saturday and Sunday at Duset Thani Hotel. Please save the dates. We have a lot of activity in this. The topics covered will be master classes, workshops, panel discussion, presentation by international speaker, poster presentation, medical, surgical, and radiological quizzes, and oration, and lots more. Well, our sponsor, Dr. Tawfiq Ali, who is always helping us, very well known to all of you. Well, I'll give a brief history of formation of neonatology, NICU, and something about the beginning of antibiotics, and then introduce our speaker. Well, a brief history of neonatology. I always start in the memory of Hippocrates, the father of medicine, and his famous quotation, which I love: first, do no harm in any field of medicine. Well, now I would like to tell you how neonatology developed. In France in 1870, there was a war, famine, and an unusual visit to poultry in the zoo made beginning of neonatology. This gentleman you see here, Dr. Stefan Tarnier, he was an obstetrician. Post-war in France, the population was less. They wanted to increase the population, and they asked the obstetrician to help. But Dr. Tarnier said everything is possible, but we have to prevent the premature deaths. One day, accidentally, he went to zoo and he saw poultry. That is, chickens are kept in a warm environment. This gave an idea to come and build his incubator. And he is known as the father of incubator. I would like to open a bracket here that earlier in Russia, George Goel, he made one incubator to Tarnier and Budin, his students. Well, now you see here, this is Dr. Stefan Tarnier and his student Budin. They are the pioneers in neonatology and perinatology. Well, Stefan Tarnier is generally considered to be the father of incubators. Pierre Budin, his student, is known as father of modern perinatology because in 1888, Budin published the work of Tarnier in the form of survival of premature babies. And there was another interesting fact that there was a student of Dr. Budin called Martin Kuney. What happened? Dr. Budin asked Dr. Kuney to take these incubators to the fairs and show them. And they went to Berlin, they kept these incubators, and later in the United States, he formed a Coney Island. He used to keep the premature babies in the incubators and take 25 cents from the people. And this island till 1933 was there. After that, they closed it. So Kuney is a pioneer of neonatology incubator in the United States also. So this is the incubator babies of Coney Island, and you see, and many premature babies survive. And interestingly to know, the first time when they kept the premature babies, the incubator of Dr. Tarnier, all 6 premature infants survived. So this was the beginning. And as I said, in Russia, George Goel developed a rudimentary incubator, but credit goes to Tarnier. And in 1857, Jean Denius was the first to publish description of its similar incubator design. And in 1931, Robert Bohr added more sophisticated upgrades to the incubator, which allowed humidity control and oxygen delivery. And in 50s, very well known in the neonatology circle, William Silverman and Richard Day and colleagues at Columbia, New York, demonstrated benefit of modifying body temperature. And please note, most remarkable, a 1 kilo infant who was born in 1960 had a mortality of 95%. Please note, 95%. But had a 95% probability of survival in 2000. See the improvements. Well, about the antibiotics in NICU, the start of antibiotic era coincided with the beginning of modern neonatology. Before introduction of penicillin, the most important organisms causing neonatal sepsis and meningitis were Strep pyogenes, that is group A streptococcus, and Staph aureus and E. coli. The Staphylococcus rapidly developed resistance to penicillin and created an extremely problematic situation in most of the hospital nurseries. And in those days, hexachlorophone was widely used to suppress the organism, but proved to have its own hazards in premature baby causing cystic lesions in the brain. So they stopped it. But when methicillin was discovered, which was effective in treating Staph aureus, there was a great sense of relief. Well, this is important to know that the difficulty of making a definitive diagnosis of neonatal sepsis and meningitis early in this course has been recognized for decades. This limits our ability to restrict. Well, today, Dr. Monica will talk the use of antibiotic to newborn with known infection. And in 70s, more attention was paid to interpretation of white blood cell count, differential, as well as acute phase protein. And in 1974, C-reactive protein was shown in Sweden to be helpful. Then the immature to total neutrophil ratio also proved to be useful. Then until the present time, no single test has proved reliable in making early diagnosis of sepsis, although this may be about to change if the PCR technique comes. Well, now our answer, Dr. Gulag, Louis Gulag. Gulag in Germany means luck. Dr. Gulag is considered to be the father of American neonatology. He has done a lot of work. Where Gulag made many important contributions to neonatology, identification of the importance of hand washing in prevention of the Staph aureus sepsis, the design of first modern open room neonatology intensive care. See, in 1960, he opened the NICU. I will show you the picture. At their university, and he developed the LS ratio, lecithin sphygmomyelin ratio, which is used by many neonatologists, and he received more than 35 national international awards, edited more than a dozen of professional journals and 300 articles. Just remember him. Well, this is his NICU. Just see, 1960 established this one. So he's the father of neonatology in America. Another, please note, all neonatologists, please note, the term neonatology was coined in 1960 by Alexander Sheffer. He wrote the first book of neonatology and later on joined by Avery. Who is this Avery? Mary Ellen Avery, also known as Mel, was an American pediatrician in 1950s, exactly 1959. Avery's pioneering research about helped lead to the discovery of the main cause of respiratory distress syndrome, RSD, in premature baby. Her identification of surfactant, please note, led to the development of replacement therapy for premature infants, and later on in 1980, Fujiwara from Japan synthesized it. And in 1991, President George Bush conferred the National Medal of Science on Avery for her work on RSD. Please remember. And about neonatology in India. I would like all my Indian neonatologists and colleagues to note this. Dr. O.M. Baku is the father of Indian neonatology. Dr. Baku said, we started the National Neonatal Forum during the first 12 years and put it on a firm foundation at the national, UNICEF, and international level. Well, this is a certificate, Dubai Pediatric Club, along with the National Neonatology Forum of India UAE branch, given to Dr. Baku. This was the ceremony held on IAP Neocon in 2019 in Bangalore. Well, I will show you a small video.
There's one more award from overseas which has come. That is from the National Neonatology Forum UAE Dubai, and NNF UAE is also honoring
this
Professor
was actually
Baku with the
given by
Lifetime
Dr.
Achievement
Monica there, who was in this conference, and this certificate will be shown close now. I'm honored to have mentors like Dr. Baku, who is the father of Indian neonatology. Well, this is the first photo of the neonatology, National Neonatology Forum. Here, Dr. Baku, Dr. Mehban Singh, Dr. D.K. Goa, and Dr. Santosh Bhargava. They are the pioneers of Indian neonatology. Dr. Baku, Dr. D.K. Goa, Dr. Mehban Singh, Dr. Santosh Bhargava. And this is a photo around mid-80s. This is a doctor from America, Dr. I just forgot his name, Dr. Paul, Dr. Narayan DK Goa, Professor Mehban Singh. Here you see Dr. Ashok Diogari Young and Sham Kukreja. I just forgot this, that the most senior famous neonatologist, Dr. Vidyasagar. Dr. Vidyasagar, who is in the United States, and other neonatologists. Just remember, a triad of neonatologists in PGI Chandigarh. I would like to bring in 1988, the first neonatology DM was established in PGI by Dr. Baku, 1988. 10 years later on, in All India Neonatology was established. And triad in the All India, Dr. Mehban Singh, Dr. Paul, and Dr. Ashok Deogari. Remember them. Here, Dr. Mehban Singh and Dr. Ashok Deogari. Well, NNF UAE was inaugurated on 22nd February 2019 in Abu Dhabi. You see here Mr. Suri, the ambassador of India to UAE, delegate of the Dr. Goswami, president of NNF, Dr. Bharati, and other member. You see Dr. Sani Korean, Dr. Monica, Dr. Rajesh, you see Dr. Sridhar, and others. Well, this is the presidents of NNF India, as you see here, Dr. Bhargav, Baku, Mehban Singh. I'm not going there just to see. And the first meeting of neonatology workshop with Dubai Pediatric Club in UAE, in Dubai. Dr. Monica sitting there. Well, as I've told you, our speaker is Dr. Monica Ghoshal, our panelist, Dr. Javed Abibullah, Dr. Jyoti Talukdar, and our moderator, Dr. Kalpana Sengupta, and Dr. Diari Muhammad. Well, Dr. Monica, everybody knows Dr. Monica, very well known to all of you. Well, Dr. Monica is a consultant neonatologist, consultant pediatrician, head of Department of Neonatology, Emirate Specialty Hospital, Dubai. He had MBBS, MD Pediatrics from prestigious PGI Neonatology from prestigious institute, All India, and fellowship from UK. She's a vice president of Emirate Pediatric and Neonatology Society and president-elect of the neonatal chapter of the IAP. She's also editor and reviewer of many journals. Here you see Dr. Monica contributed to many books, Cloharty, Clinical Neonatology by IAP, so many publications. Well, this is the future of the neonatology. Our lab-grown babies and artificial womb, the future of neonatology, the way it is going. And here, with the advent of this artificial intelligence, I think easiest way of having the baby in future will be like this. You just press print, you will have the baby. Well, my references, thank you very much. Now, I would like to invite Dr. Monica to join and start her talk. And I would like to request all viewers to write their question in the Q&A box. Then we will start panel session. Dr. Monica, please.
Thank you so much, Dr. Saurabh, for inviting me and for such an elaborate talk on our neonatology, how it progressed in India and here. So my topic is very important. I would say that talking about zero antibiotics in NICU, is it possible or not? So I will just take you through the session to decide later on by everybody whether we can do it or we can't do it. So I would take you to a Danish study, which was also talked in Hot Topics 4 years back when I was there. And it talked about antibiotic resistance increase in the NICU, even in early onset sepsis, where 82% increase of resistant bugs like Acinetobacter, 54% Klebsiella, and 38% of E. coli bugs were there. And these bugs were actually causing much more population attributable risks, as well as mortality rates were much more when the babies were with this multi-drug resistant sepsis. So not only that, also there is a financial implications whenever we deal with such kind of bugs in our NICU. So why these rise in multiple drug resistance has occurred? This is because of gap in infection control and over. And in one of the newborn who was sick, so many antibiotics were being given and changed. And this is one baby where so many antibiotics were given, and this is what sometimes we see. Now, why this has increased? Because of places where there's a lack of antibiotic stewardship programs, there is a poor adherence to the hand hygiene, over-reliance on the CRP for our diagnosis, and treating colonization rather than really a bacteremia. So also we talk about, when we talk about hand hygiene, overuse of water, and specifically in the places where there is a contamination of water. So people are talking about it, that should we go for waterless NICU, or putting those sinks very near to our babies' cribs might also cause a lot of pseudomonas and candida infections rise. So instead of that, could we go for a chlorhexidine wipes for bathing, or improving compliance on how we do hand washing? And if we are using surgical scrub, then how do we really use that scrub? That's important, and I'm not going to go in detail of that. Another thing which is important is use of antibiogram, and how do we use it? How do we look at it and put it into practice in our daily use of the NICU? How these MDR bacteria grew with normal isolates with the wild types, which were totally sensitive to the normal antibiotics which we are using, to a resistant antibiotic where we have acquired or multifactorial resistance. And then in between, there is a intermediate time, and then there's a clinical break point where resistance is increased. So I would like you to look into this. This is very important. Which antibiotic is better? So we all know that we look into minimal inhibitory concentration, and that's what we look at. But I would like everybody to go beyond that, where we also have to look at break point. So antibiotic X, where MIC is 0.50, which is much lower than antibiotic Y, where MIC is 2, looks to be much better antibiotic to be used for a certain baby. However, if we look at the break point, where the break point is 1.5 in this, so how do we decide antibiotic would be much more useful and effective? It is MIC divided by break point. So 0.5 divided by 1.5 is much more than 2 divided by 12. So if we just look at MIC, we would have given antibiotic X. But if we look at the real MIC divided by break point, antibiotic Y is better. So we have to go more in details. And here we have a microbiologist with us, which can also explain in a better way. Then there is antibiotic use metrics for NICUs, like how do we measure antibiotic utilization? That's the first step to improve the use. And the various metrics of antibiotic use have been proposed. there is actually no uniformity which is accepted specifically in our neonatal settings, because we all learn from adults and then pediatrics patients. The main is which is come up is antibiotic use rate. So which is means number of days an infant was exposed to one or more antibiotic divided by total length of hospital stay. So this is at the patient level. And if we want to look at central level, then it will be or on per patient days. So this is expressed as proportion or percentage. So this has an effect on duration of hospitalizations and mortality. And this is used in WAN and CDC when they talk about choosing antibiotics wisely in any quality improvement initiative. So what challenges we have when we are talking of antibiotic use in NICUs? We have polypharmacy and a combination therapy. We have a lot of places where we are antibiotics. We have babies with culture negative infections. We have changing clinical guidelines and emerging resistance, and difference in the data quality and standardization. And of course, also we have a patient heterogeneity. So there was a paper published in 2023 from US where they looked into their NICUs over last 13 years from 2009 to 2021. And around lot of babies who were admitted were included. And what they found was 44.8% of these babies who were admitted in the NICU received antibiotics. But the good thing was, if we compared from 2009, it was 54.8%. And now in 2021, it was reduced to 35.9%. So we are actually going in the right direction to some extent, but we have to improve further on. And days of therapies were 274 per 1,000 patient days in average. So the future directions seeing this is that you have to have utility of antibiotic use metrics, balancing them with the burden of data collection and analysis. And it's important for risk adjustment, which is very critical, so as to avoid penalizing institutes, because there are some institutes who are caring for more sicker babies, higher risk patients. So risk adjustments should not be the same in those two different NICUs, which are dealing with two different kind of babies. And continued analysis of existing metrics and simultaneous exploration of novel metrics are crucial to improve our ability to monitor antibiotic use. So this is important. I would take you to cases so that we can learn better where we can use antibiotic, and where we should have not used antibiotics. And all of you, when you look at these cases, you must have been seeing these patients in your day-to-day practice. So let's go for case one. Baby Y, 33 weeker, 1.5480 gram, born vaginally to a gravid 2 mother, unbooked pregnancy, received 2 doses of dexamethasone. And her maternal risk factors for sepsis was that she was leaking for 48 hours. Her counts were 18,800 with neutrophils of 90%. Baby cried immediately, had good EPCAR score, was admitted in the NICU because of the respiratory distress. Silverman score was around 4/10, so started on CPAP. Required CPAP of 6 with 30% of oxygen, was 93% SATs. Hemodynamically quite stable. So now what should we do in this baby? Should we do the septic screen? Should we start the antibiotic? What should we do? You can write in your chat box what you would do so that we know in the end what should have been done in this baby. So discussion goes on, and in the discussion, we talk about evaluate the risk of early onset neonatal sepsis in the neonate, especially it's a preterm baby, 33 weeker. So do you think that one should be doing this at risk evaluation in an asymptomatic neonates at birth? What are currently available risk scores which we can use? What is the sensitivity and specificity of these scores, and are they really valid? Is there a guide as to what scores is the best to use? So let's see. At risk evaluation in asymptomatic neonates at birth. Whenever we do that, we reduce the exposure to antibiotics, we reduce cost in hospital stay, and we don't increase the mortality or morbidity. So what are these risk calculators? One is the risk factor-based approach and Kaiser permanently score. And then there are lab scores, which are hematological scores, and there is a neonatal sepsis panel, which Dr. Sora was talking about. So when we talk about risk factors, there are two kinds of risk factors. One are the simple risk factors, and the other ones are extreme risk factors. Now, talking about simple risk factors, where there is a spontaneous onset of preterm labor, or a prolonged duration of labor more than 24 hours, prolonged rupture of membranes more than 18 hours, intrapartum isolate moms having fever of more than 38 degrees centigrade. So when we talk about these risk factors, if we have more than 2 of these risk factors, we do septic workup. Here we still don't start antibiotic. We are doing the septic workup. If we have extreme risk factors like a foul-smelling liquor in this preterm baby, maternal septicemia, chorioamnitis, we do start antibiotic irrespective of any scores. So the unit protocol for the risk-based approach is, when do we start antibiotic? If we have risk factors, we have a preterm baby with 2 or more risk factors for early onset sepsis, which we already talked about: maternal fever, foul-smelling liquor, rupture of membranes, unclean vaginal examination, perinatal asphyxia, when we say EBGAR less than 4 at 1 minute, and clinical chorioamnitis in mothers. So whenever we have 2 or more risk factors, we start straight away antibiotic. And another is clinical or sepsis worker-based approach. If we have strong suspicion, now where our baby looks septic, it's in shock, scleroderma, sepsis in the scotwin, we can start antibiotic. Or any baby with at least 2 risk factors for sepsis plus septic screen is positive, we start antibiotics. So the clinical risk calculator, Kaiser permanently calculator, is validated for more than 34 weeks minded. Some of them are using for little smaller babies as well. And maternal GBS positivity on the assessment parameters is taken into consideration. So what is this calculator? Very easy to use. One is what is the risk of sepsis, and then the gestational age. How much is the temperature of the mom? How much is the rupture of membrane duration? Maternal GBS status positive or negative or unknown? And the intrapartum antibiotics given to the mother, less than 4 hours or more than 4 hours, adequate ones or not. And then, for example, we filled this for a baby with 35-weeker. Mom had 101 temperature, 16 hours of PPRM, maternal GBS negative, and broad-spectrum antibiotics is given, then risk scores as 3.88. Now, this has to be added with the clinical status of the baby, which may be either well baby. If it is well baby, when we combine with this risk score, the overall risk comes 1.60, which means just take the blood culture and keep evaluating the baby every 4 hours. If clinical status is equivocal, that we don't know, we're not sure, which may happen most of the times, then risk per 1,000 births becomes still a bit higher, 19.12. You start empiric antibiotic, but keep evaluating, and then you can stop. If there is a clinical illness, the risk score goes very high along with the score, and you start definitely antibiotics. Then is a hematological scoring system, which was started by Broadwell in 1988, which looked into, now this is scoring different from a septic panel, you know. The scoring, it gives score. So IS to T ratio gives the scoring, total polymorphin counts, scoring, increase or decrease, score 1, immature polymorphin 1, WBC count, less than 5,000 or more than 25,001, degenerative changes of polymorphin nucleoside, if more than 3 gives score of 1, and platelet count if less than 150,000, again score is given 1. So this scoring system, when you combine, if you see alone, they have high like sensitivity, but specificity is quite low. When you combine them, the lower the score, sensitivity is very high, but specificity is very low, as you can see here, 141. As you go higher on the score, the sensitivity becomes lower, but specificity becomes high. So we have to draw our line in between. So if we take score of more than 3, preterm infants less than 24 hours have a very high sensitivity of 100, and even term for less than 24 hours of 100, and specificity is quite okay, 82 and 74. So can be used. Then is the panel. Panel means total leukocyte count less than 5,000, absolute neutrophil count, which is different for term, which is seen by Monroe's chart, and different for preterms, which is Ozino's chart. That is seen IS2 micro ESR in first hour more than 15, CRP more than 1. So it's very important when you do the septic panel, because if you do less than 6 hours, you have not given time for the inflammation to respond. So it has to be done after 6 hours. And if 2 parameters of these are abnormal, then sensitivity to get infection is 93 to 100%, specificity is 83%. It has a very high negative predictive value of 99%. So if 2 parameters become positive, you start antibiotic. And if you have 1 abnormal, then you repeat after 12 hours. If you look at these sepsis markers, and individually, if you look at them, they don't have that much of high sensitivity and specificity. So individually, they cannot work alone. So if we discuss, elaborate on, based on this, what we have, there is a jury to decide what we do, what sepsis screen results. There is eyewitness, which means clinical monitoring, my eyewitness, and there is a circumstantial evidence. So we look into these, and then the jury decides what to do. So what is testimonial against sepsis screen? That is a circumstantial evidences, which says that poor diagnostic performance. It either get overdiagnosed or underdiagnosed of sepsis. There is a misuse of antibiotics. Better alternatives, clinical monitoring, and rapid infection detection methods. So these are our circumstantial evidences. So what are the examples when we don't really need sepsis screen and we have to start antibiotic? If baby looks sick, shock, we need to take a blood culture, start antibiotic. So we have to know do's and don'ts. Do septic screen to be done only when you think you are going to change your decision. So save time and money. Do not use septic screen to decide duration of antibiotics. Treat the baby and the culture. And do not use septic screen as a substitute for a blood culture. So our gold standard is our blood culture, whether it is blood or CSF or urine. And positive blood cultures, 20 to 40% of cases only the sepsis. Why we have low positive results? Because we are not taking enough blood volume. We have a transient or low-grade bacteremia. We take blood culture after we have given antibiotic, or the moms received antibiotics during intrapartum period. And I'll talk about blood cultures more in more elaborate. So the summary for a risk evaluation is clinical scores may have a role. Better to use sepsis scores like Kaiser Permanente, but need to contextualize to our environment. Most sepsis scores are validated for actually more than 34 weeks, but still we use it for premature babies. And single extreme risk factors which can ask you to start antibiotic is in a premature baby, foul-smelling liquor, chorioamnitis, and maternal sepsis. So for a summary of what we learned for a sepsis screen is, it may have a role in late onset neonatal sepsis. For early neonatal sepsis, it should be rationalized for reactants which have a quick generation and peak times. And as we saw, one parameter cannot actually diagnose as well as cannot tell us of duration of antibiotic. And as Dr. Sarab also mentioned, we have, and I will talk about it, rapid diagnosis by PCR-based test may have a role to begin. So when we learned all this, let's come back to our case. What would we do when we have this knowledge with us? So this case, was there any risk factor for sepsis in this baby? Yes. There was a spontaneous onset of preterm labor. There was a prolonged leaking per vagina. There were 2 risk factors, but were there any extreme risk factor? No. So what do we need to do for this baby? Don't start antibiotic. but we need to do a septic screen. So we did a septic screen where we found total leukocyte count 9,800, ANC 4,500, CRP 6, IT ratio 0.3, and microESA 10. Negative septic screen. So what do we do with this baby? Should we give antibiotic? Should we give feeds? No need of antibiotic. We didn't give antibiotic. There was screen was negative. Monitored on CPAP, weaned from CPAP, came on room air, feed started, full feed on day 5, did KMC, mother counseled to give mom's mother's own milk. By day 4, she had a complete MOM, transited to breastfeed at day 10 and regained birth weight on day at 9-day discharge on 34 plus 5 weeks on breastfeeds. So learning point from this case was look for maternal risk factors for sepsis in all cases. Do sepsis screen only when required. Not all preterm neonates require antibiotics. What about other diagnostic tests? You work in a replete environment as far as the logistics and resources are concerned. So we are all talking about procalcitonin and biofire. So what are the role of procalcitonin isolated or with other markers in early onset sepsis? And what is the role of biofire in NICU? So let's talk about CRP and procalcitonin. So if you see this chart where culture positive sepsis is red, which is very small, and culture negative sepsis giving antibiotic for more than 5 days are huge number of babies in every country, and culture negative sepsis giving for less than 5 days are still less. So we need something more for these culture negative sepsis to see whether we need to give antibiotic or not and for how long. So procalcitonin came into picture in early onset sepsis. And this was a paper in 2019 where they looked into, combined all the papers and found that sensitivity and specificity of using procalcitonin in early onset sepsis was very low. It was in the center, so it was quite low. And then there was another paper which was published after that in 2023, which looked into 1,204 neonates with eligible cultures. 12.9% had a culture positive sepsis. And they also found that serum procalcitonin did not reliably identify culture positive sepsis in neonates. So where do we use this procalcitonin then in early onset sepsis? So basically, if we have a negative culture, but if baby didn't have a good score and infection is unlikely, low risk, or infection medium risk, then at least if you do procalcitonin and 2 consecutive procalcitonin, if we do, we can stop this antibiotic within 24 hours as compared to when we don't use it, where we use and keep on using antibiotic for 36 to 72 hours in babies with low score and 5 to 7 days with just score of 2. However, the babies who had high risk of infection or infection proven, there was no difference when we use procalcitonin. So you should know when procalcitonin has reduced the antibiotic therapy days, which was 55 versus 65 hours, and hospital stay was reduced in these babies, and there was no increase in death or reinfection. What about serial CRPs? So CRP measured serially at onset and over next 2 days was a trial done, prospective trial was done in 1998 by Benitez. Initial normal CRP was not sensitive enough to withhold antibiotic. 3 serial CRPs increase the sensitivity to more than 90% and specificity to 85%. So you need to do serial CRP to be really more confident on that. And if you get 2 CRPs less than 1 in 24 hours apart, 8 to 48 hours, that means bacterial infection is unlikely. So that means that in negative predictive value of normal CRP was 99% in early onset and 98% in late onset. So negative predictive value is quite high with CRP and CBC when you do together. So if at 36 2 CRPs at 36 hours normal, no need to repeat later on. So this is what we understood, that procalcitonin better than CRP, slightly higher sensitivity but lower specificity. Now, I wanted to talk more on blood culture, which is we are taking as a blood gold standard. But you must know that the sensitivity of blood culture depends on when did you, what was the site of sampling, number of the cultures you have taken, volume of the blood, which is very important, and type of culture bottle you have used. So nowadays, all of us are using Bactec. So ideally, before giving antibiotic, the culture should be taken, and the baby should be really having bacteremia at that time. Whenever you change antibiotic, you should take another blood culture, and it should be taken under aseptic precautions with proper skin preparation with 3 swab techniques. And there were debate of 0.5 ml to 1 ml. I would say at least take 1 ml of blood for the blood culture to have a proper thing. But you don't need to have 2 sites. There were studies which was done which said that one site, if more than 1 ml of blood was taken, is good enough to give us a idea. When do we take anaerobic blood culture? True anaerobic bacteremia is rare in neonates. However, there was a study in 2024 where a retrospective cohort of 3,665 newborns were seen and 182 paired cultures were sent. Organism detected exclusively in anaerobic cultures, 17.6%, when both bottles recovered pathogens. And anaerobic bottle had a shorter time to positivity. So when you should use this? When you have a situation like neck or when you have maternal chorioamnionitis, but routinely not recommended. Some of our colleagues also talk about using umbilical cord blood for culturing. And the benefit of using this is that we don't have pain infliction to the baby. Technically, it is less challenging. You can take adequate amount of volume. And so phlebotomy losses are reduced. One of my colleague, friend in Pune had done this study and had found a lot of benefit of that. And but however, there is chance of contamination from maternal vaginal skin flora. When a meta-analysis was done comparing this to umbilical cord sampling to peripheral blood sampling, they found higher sensitivity comparably and comparable specificity when they use umbilical cord sampling to peripheral blood culture. So you can do that. Another thing with for how long do you wait when you send the blood culture? So time to come positive. So most of the neonatal bacteremia, they are positive within 24 to 36 hours. There was an observational study in early onset sepsis where 594 positive blood cultures were studied, and they found that 21 hours was the median for coming positive, and it was from 17 to 25 hours. So blood culture positive by 24 hours in 68% cases, and by 36 hours, 94%, and at least within 48 hours, 97%. So if nothing is growing within 48 hours, please, you should consider it as negative. And another observational study had shown it to be positive in 23.5 hours. All cultures are positive within 36 hours, except for corns, which grow slowly. And so empiric antibiotic therapy in late onset sepsis can be stopped at 36 hours. Now, when you talk about MDR, like so you have already given 2-3 doses, different antibiotic, and now you're thinking it is MDR, you started cholesterol in your baby. If you don't grow anything within 24 hours, it cannot be MDR because that bacteria is going to grow fast. So don't wait for 72 hours and keep giving cholesterol to cause more drug resistance in the thing. So please stop if within 24 hours you didn't grow anything. We all understood that at least 24, 36, 48 hours it takes for blood culture to come positive. So what can be more quicker? So there is a BioFire, which is a PCR assay for molecular diagnosis. And most of the bacterial pathogens in the NICU can be diagnosed. It can directly identify pathogen, reducing TAT and hands-on time. Result can come within 4 hours. and less affected by prior use of antibiotics. So you can see that when you draw a DTA sample, within 30 minutes, it lyses the red blood cells and remove hemoglobin. Within 15 minutes, bacterial lysis buffer occurs. In 45 minutes, DNA isolates occur, and 2 hours more, multiplex PCR comes positive. So maximum 3.5 to 4 hours, you come to know about these bacteria. So good thing if you have that facility. Now let's go to second scenario. We often have the scenario when you have a term baby with respiratory distress, no antenatal risk factor for sepsis. Should antibiotic be started in this situation? How to decide for an or against antibiotic in this situation? Meconium aspiration syndrome, TTNB. So let's take an example, 38-weeker, 2.8 kg, born vaginally, to a primary mom, booked pregnancy. There was a history of meconium strain amniotic fluid, no risk factor for sepsis. Baby cried immediately, APGAR normal, but had respiratory distress. So admitted with 5/10 Downey score and started on CPAP of 5, 30% oxygen, SATs was 94% in right upper limb. So now this baby what should we do next? Is a septic screen required for this case? Should we start empiric antibiotic? Should we give feeds or not? This questions come to the mind. Now let's talk about antibiotics. So there were studies in 1967 by Bryan, 2002 Edelman. They showed that only sterile meconium had a very good outcome and babies with poor outcome were with culture positive meconium. So when these studies were combined, routine administration of antibiotic was seen not to be needed. Screen babies with MIS for sepsis. If evidence of sepsis and baby looks sick, then start antibiotic. After this, there was a Cochrane study which showed that antibiotics did not decrease the risk of sepsis in neonates when you diagnose their meconium aspiration syndrome. Not also in an asymptomatic neonates exposed in a meconium in amniotic fluid. There was no difference in mortality or duration of stay, and quality of evidence was low. So they said there is no role of prophylactic antibiotic in meconium aspiration syndrome. And there was 4 RCTs which were included in this Cochrane. After this Cochrane, there was another study, randomized trial for looking at in prophylactic antibiotic in neonates born with meconium strain liker, and there were other studies which were included, and they found that the incidence of culture proven sepsis was not significant different between the two groups where the antibiotics were given or the antibiotics were not given, and the incidence of mortality, meconium aspiration syndrome and other complications were comparable between the two groups where antibiotic was given or not given. So when we have these 3 big evidences, and we have this baby coming back to our baby where there was no maternal risk factor for sepsis, baby settled on with respiratory support of CPAP, no septic screen is required because there is no risk factor for sepsis, baby was kept on monitoring for worsening respiratory distress, no antibiotic was required, and baby was on full feed. Baby was weaned off from respiratory support on day 5, initiated on breastfeed, discharged on day 8. So learning point from this baby was not all neonates require sepsis screen. So in this baby, not even septic screen was required. Antibiotics are not required in all cases. And not all babies born through meconium strain liker require antibiotics. Now coming to babies, premature babies who are put on ventilator or any ventilator support, should we give antibiotic or not?
Monica, 5 minutes, please.
Only 5 minutes? Preterm babies who need CPAP, surfactant therapy with classical finding on X-ray. How should we decide about start of antibiotic in the following situation? Baby on mechanical ventilation, has apnea, episode of feed intolerance. So if baby required mechanical ventilation, which X-ray may look like pneumonia, can consider screen and antibiotics if prenatal risk factors are present like prolonged rupture of membrane, maternal fever, or chorioamnitis. If associated features like hypotension, metabolic acidosis, apnea, lethargy, then you can give antibiotic. Secondary worsening on CPAP, if it is happening like dope, and we have looked after the differential like HSPDA, IVH, Ehrlichs or CCHD, then only antibiotics to be given. Otherwise, no prophylactic antibiotic for any mechanically ventilated neonates. What if the baby has apnea? If apneas are recurrent and refractory, if associated with lethargy, hypertension is looking, isolated apnea, but sepsis screen positive, then you can. But you have to rule out again PDA, neck, IVH, seizure, electrolyte disturbance. So avoid antibiotic for isolated apnea if no other signs of SIRS. If baby has feed intolerance, so usually babies on CPAP, consider CPAP belly. If you have IGR or you have placental insufficiency, that could be cause of signs of neck and other severe sepsis. If we have a severe sepsis sign, hypertension, scleroderma, metabolic acidosis, start antibiotic. Otherwise, don't start antibiotic and think about other causes of feed intolerance. So if we have a baby, any clinical deterioration, think of non-specific mimics. If they are not there, then probability of sepsis might be there. Single episode of apnea, single episode of feed intolerance, probability is quite low. Do a septic screen. If septic screen is positive, then only start antibiotic. If we have a high probability of sepsis, that is hypertension, scleroderma, metabolic acidosis, bleeding, lethargy, then you can start antibiotic in these babies. So, if you have a sick baby, definitely you will start antibiotic. If baby is in shock and other reasons you have ruled out, you can start antibiotics. So, I would say, sepsis mimic like PDA, IVH, Ehrlich, neck, drugs, dyslipidemia, you should rule out. TTNV, MAS, ventilation, CPAP are not indication for antibiotics. Shock can also be due to other causes, so rule those out and then only start. What if one twin is having infection and the other one, should you give antibiotic or not? If the other baby looks okay and fine with minimal setting of CPAP, we know that spread of infection through vascular connections is theoretically possible. Spread of infection from amniotic fluid of an exposed twin to co-twin may occur through intact dividing membranes. However, if baby is fine, the other twin is fine, we don't need to start antibiotic. We just need to look at clinical deterioration. And if there is any, then only start antibiotic. Feed intolerance, we already talked about that. Even if you have put UVC, UAC, and there is little bit of feed intolerance, and you don't need to start antibiotic. You can send the septic workup and culture, and only if there is worsening, you start antibiotic. And I'll just skip this because this one we started antibiotics, so I don't want to start this. So we need to reduce antibiotic duration, 48 hours timeout, duration of therapy for pneumonia 5 days, culture positive 10 days, and blood culture report downgrade. Whenever you get downgrade the antibiotic, give the narrowest spectrum antibiotic. If there is a culture negative sepsis, only 5 days, and avoid using CRP and procalcitonin for this. Another, because Dr. Diary is there, pre-surgically, I just took one case, ruptured of meningomyelocele, and he's awaiting the MRI and evaluation of neurosurgeon for optimal time for surgery. Should antibiotic be initiated in this condition? What are the indications for prophylactic antibiotics in this baby? So there was a study which showed that factors affecting infection development after meningomyelocele repair in newborns and efficacy of antibiotic prophylaxis. They very clearly said routine prophylactic antibiotic use did not reduce infection risk in MMC repair surgery. Thus, antibiotics should not be used if there are no risk factors predisposing to infections. So, summary of late onset sepsis and prophylactic antibiotics. LOS are most diagnosed on clinical presentation. One should look for sepsis mimics prior to start of antibiotics, and prophylactic antibiotic not to be used. Antibiotic may not be required on the pre-surgery cases. Another, do I have time? That we should be always looking into if late onset sepsis is coming, we must look into whether it is bacterial or a viral infection, because viral infection babies can also present like a bacterial thing. So always we should keep in our mind, specifically when we have baby coming back to us with history of fever. Then you look at if there is a runny nose or not in the family, cough or fever is there or not in the family. And we have to also look into HSV, especially they all, if the baby is born to a mom with HSV, they also will be having seizures and sick looking. So must always see these history and send the viral panel. And must know that neonatal sepsis can create muscular clinical skill to differentiate real sepsis from many mimics we should have. And we should have more clinical monitoring. I'm sure AI will take us over, but still till then we have to use our brain and our eyes and our knowledge. And blood culture should be kept as gold standard. So we should have pharmacist-driven antibiotic and prevent infections. When not to use from my slides, simple asphyxia or need of resuscitation, severe neonatal jaundice, meconium aspiration syndrome, asymptomatic preterms with no risk factors, surgical newborn with clean surgery, empiric antibiotic to suspected early onset sepsis, preterm delivery by cesarean section without ROM, without chorioamnitis, indwelling catheters, central lines, invasive ventilation, TPN. These are not the cases for giving antibiotic. Should know the colonizer if you have cons. If it is just a colonizer, don't start antibiotic, and restrict antibiotic in simple viral infections. So there was a QI to reduce antibiotic thing, and all of us in our NICUs should, I don't have time to talk in detail about this study, very, very good study, which did a QI, which implemented medical leadership support, multidisciplinary infection committee, updates on guidelines, education to everybody, and implementation of antibiotic timeout at 48 hours. Monthly reports were put of AUR, EOS, LOS, antibiotic resistance, clinical sepsis and NEC. And all these were implemented, one by one, started from 2018 to 2020. And how much reduction in antibiotic use and the number of antibiotics per patient was reduced is very commendable. And we can, another study in South Africa had the similar effect, where days of therapy overall came down from 9.1 to 6.9, and days of therapy of culture negative sepsis from 8.2 to 5.9 by all these quality initiative studies. So we must prevent infections by hand hygiene, water management, having an adequate nurse-patient ratio, and bundle care to be given, intravenous cannula care, central line care, WAP bundle, nutrition bundle, and nothing like mother's own milk. Family-centered care in the NICU, and we will win in the end.
Thank you very much, Dr. Monica, for this excellent informative talk. Now I would like to request Dr. Javed, Dr. Jyoti, Dr. Kalpana, and Dr. Diari to join us for Q&A session discussion. Now I would like to request Dr. Kalpana Sengupta, Senior Consultant Pediatrician, Head of Department and Secretary of the Club, to start the Q&A session. Please.
Thank you, Dr. Saurabh. First and foremost, thank you, Dr. Monica. I think this is a topic for a conference which can go on for, over many sessions. But you have done a very good job of giving us the salient features. A lot of debate will go on. I would like to invite Dr. Javed. Dr. Javed, you can put on your camera now.
Dr. Monica, you stop sharing, please. Yes. Dr. Javed, please join us. Your camera. Yes, please.
Yeah. So before we get into the question answer session,
you can hear me?
Yes, Dr. We can
Yes.
hear you.
Thank you very much, Dr. Monica. You have done a great job, actually. It is a very controversial topic which you started. I have got a few comments that regarding the scoring system. This scoring system is now totally changed, actually. Now there is many scoring systems come. First time, Dr. Richard Pollan, he put they called ANSOFA scoring system. So this was the how to find out that the baby is septic or no. So this was only based on the respiratory scoring, like whether the baby is intubated, not intubated. It scored from 0, 2, 4, 6, and 8, and the oxygen saturation and the need of oxygen. And then there was the cardiovascular scoring, which was about 0, 1, 2, 3, and 4. So total of 15 with the criteria. And the hematological, only 3 things he put it. And according to many studies done after that, and they found it is a very good, you can find out which baby will need antibiotic, which baby is having this problem or no. But there were quite things are missing in that, which Dr. Pollan did it in 2015 and later on published in 2016. And till now, many studies are coming up. Most of them, there are different results they mention about this. After that, there is other studies came after that. For example, they had neo-OBS studies, then they had neo-ACD studies, then they have got pro-ABIS studies, I mean the scoring system. So many of them now they added procalcitonin. Procalcitonin, when it is coupled with the clinical condition and CRP, it becomes a very good indicator to whether baby needs antibiotics or baby doesn't need antibiotics. So, for example, all these things should not be decided immediately after birth. So at least it needs 6 hours. After that, PCR maybe, because all of them, they will be negative at birth. So procalcitonin, if you couple it with clinical condition, that is the first thing. It's a doctor job, because he will look at the patient, he will know baby needs antibiotic or doesn't need, baby look septic or no. That is the first thing he has to do it with examination. And then if the procalcitonin at 6 hours age and afterwards, it is more than 5, this means very high chances are there that the baby will be infected. Because the blood culture, although it is a gold standard, but in now the latest study shows that not more than 9% had got positive blood culture, even they were septic, clinically septic. Some study shows 24%, some maximum 40, there were old studies. But the latest study shows only 9%. So it is mainly the doctor's job to decide about this one, not only depend on the blood culture. So procalcitonin, when it is more than 5, most probably baby is infected. If it goes more than 1, it is strongly tells you that you have to be ready for the antibiotic starting. And this has got a good thing inside. If you see the CRP, because CRP is something, it is which is with any inflammation, it will go up. But in procalcitonin, which is from the precursor of the, this is from the thyroid gland, it's coming from the precursor, that one calcitonin hormone, which is from the thyroid C cells. So that one is very important if it is more than 1. So if you have got a CRP, for example, more than 5, you have got this one more than 1. So you go, there is now many algorithms they have made out of it. So it means most probably it will need antibiotics. Starting antibiotic is not a problem. This we have to keep in mind. Whenever your gut feeling is telling that the baby is infected, it's better to start the antibiotic, because if experienced neonatologist look at the baby with all the risk factor in his mind, and with coupled with this procal and CRP and the CBC, for example, WBC count is less than 5, severe leukopenia, or he has got a, for example, very high neutrophils or toxic granulation or immature cell like band cell, myelocyte, paramyelocyte, all these things, if they're positive, and if there is a risk of history there, it's better to start the antibiotics. The only thing is you have to stop very early. We have applied this in our NSUG when I was in the Chief Hospital, and we were stopping antibiotics 36 hours, and we did not have any problem. If these things become negative, and baby remains clinically stable, and the labs are normal, you can easily stop the antibiotic. And we did it, and we never had any increase in mortality after 36 hours. Now, regarding the blood cultures, which is the time for the to be positive, most of the organism they found, if they are positive blood culture, it will come E. coli and the staph will come very fast positive. And usually it is around 9 to 10 hours median. This is the fastest organism which will be positive. And the only thing which comes are GBS and staph. And the only come which is later, it is a cones. That is a coagulase negative staph, like staph epidermidis, staph capitis, staph hemolyticus, all these things, which are usually not so much pathogenic. So if the culture is negative after 36 hours and the labs are normal, so you can easily stop the antibiotic. And if the CRP is less than 2, cutoff point is 0.02. If it is less than that, that can be done. So this is all I wanted to tell. If any question comes, I will arise. I will just go ahead for any answer. Thank you very much.
Okay. Thank you, Dr. Javed, for your initial comments. Yeah, so as far as starting the antibiotic goes, as you said, clinicians' experience comes into the picture. But is that Dr. Monica has stressed on the sepsis screen and the scoring. So that's important. Yeah. Yes, Dr. Monica.
Basically, that's what I was trying to sell. I mean, there are many scores which are available, so we should know what my thing was, that use a septic score, but look at the clinical picture. And procalcitonin use alone, I would never go to, like it. There's a debatable thing, and I have my studies with me which shows it's of not use. And in my clinical practice, when I'm talking to my neonatologist friends, some of them are using, some of them are not using. And I would say never use one thing which, cannot have a reliability to just start your antibiotic. And that's why I elaborated on, gave scenarios where you could and you could not use those markers. Some of the scenarios you don't even need to do a septic workup.
Yeah, sure. No doubt about this.
So yeah, and we are talking about serial CRP. So I never give an emphasis of a CRP positive, because we all know that CRP can be positive with so many other things. And that's why we talk about negative predictive value of CRP being negative. You don't need to start antibiotic. We didn't emphasize on positive predictive value of CRP. So I said if the CRP came negative for, you have done twice within 48 hours and it comes negative, no point, that you start. So there is a high negative predictive value for CRP.
Yeah, sure. CRP is not. But sorry,
so
I am
that's what I
interrupting.
was trying to say.
But I just request you to have a look on a paper. This was which I giving the now reference. This was tropical medical infectious disease, 2024.
I know that, but because I'm
It
not
was stop in time.
procalcitonin
How
fan,
to
I'm
reduce
not
the
there. Because if I give you data of my own unit, because we have to do procalcitonin for almost all our babies, because of the insurance people, they don't accept our infection if procalcitonin is not done. And believe me or not, I will give you my unit data where procalcitonin has come so high in so many babies, and I have not given antibiotic, because I've seen clinically the baby was fine and everything is okay and baby remained fine. So, that's a debatable thing, but I would say alone procalcitonin, I would never give an antibiotic based on that.
No, this is, as I told, we don't decide on one thing.
Yeah.
So keep the clinical condition, risk factor,
there's a
DPC
hematological
result.
factor, there is a septic panel factor, there is a clinical factor, there is a scoring system.
We don't decide on one. But the most predictive in this test, you try it. We have done it a lot for this one. I'm over the last maybe 38 years, I'm doing only on infectious diseases. And this is our finding, that the procalcitonin may be one of the best with CBC if you see it. If you have got immature cell, toxic granulations, high WC, shift to the left, these things are also very important with clinical condition. First is the clinical condition. Thank you very much.
Dr. Monica?
Yes.
Thank you.
You will come for the surgical
Thank-
case.
No, not for the surgical. Thank you. Thank you very much for your nice presentation. Now there is a question about fever in newborn. Would you
Yeah.
start antibiotic immediately, or you will go for
Yeah,
the
so that
Only
I was
fever.
giving that
antiseptic
example of the baby with the fever who came to. So it depends on, like, when the baby is coming to in your unit with fever, what do you do? So that example I was giving. So baby is coming from home with a fever, then you definitely you will admit a neonate with fever, and you can't just send them home. You're going to clinically observe, and you will take a good a good history where you will see what is the history of the family having runny nose. And nowadays we have lots of viruses with and I have two babies admitted already recently in an ICU where I didn't start any antibiotic. The baby came with a fever. There is a family history of runny nose, cough, or something like that. We have babies coming back with COVID, RSV, influenza. So we need to rule those out, but you need to definitely keep in a close observation, look at clinically how the baby is behaving, send septic workup along with the blood culture, and do a proper thing. And only if you have strong suspicion of bacterial infection, then only I would start antibiotic. Or if the baby coming fever and have symptoms of poor feeding, lethargy, excessive crying, irritability, and vomiting and all those stuff, which can also still be viral, but you can start antibiotic. Look at your panels, respiratory panel, PCR. Nowadays we have very good panel which we get result very quick.
And if you have a suspicion of early sepsis, early onset sepsis, do you do CSF?
Yes, if we have all, if I start antibiotic on high suspicion of infection, I would do CSF. Yes.
And
Dr.
do you
Diari,
come across
you're
of any
talking
study
about
how
the
many doses of antibiotic or how many days can affect your blood culture positivity or CSF?
Blood culture positivity can be even if you give one dose of antibiotic, it may change, and that's why we say that take the blood culture before. Already, which Dr. Javed said that the blood culture positivity comes in on, and I also said 25 to 40% of the blood culture comes positive. And if we have given antibiotic, then the chances of even the moms getting antibiotic antenatally or just before delivery decreases the possibility of blood culture coming positive. So definitely it reduces.
Sorry, Dr. Diari, I will add one thing. Usually, early onset sepsis, it doesn't come with meningitis. Usually, unless there is a prolonged rupture of membranes or something else is with that one, usually it doesn't come. So we do blood culture in our setup if the baby, CSF, only if the blood culture is positive in these cases. If blood culture is negative, we just give the meningitic dose because all neonate which we give the dose is nearly high. So we continue that antibiotics and we follow the other parameters clinical as I just told you. With other scoring system, we do it, and then we stop antibiotic. Everything remain negative.
Thank
It depends on how the baby is
Jyoti
presenting.
is there.
Yeah,
Yes,
I
yes.
wanted to add one thing regarding blood culture. Dr. Monica has already explained well about collection of blood culture. I just wanted to add that competency of the staff who is collecting blood samples is very important, especially in neonatology ward. So competency assessment should be done for the staff who is assigned for, and dedicated staff should be assigned this job. And another thing is antibiotic skin disinfectants should be selected as per gestational age of the patient. 3-swab technique, doctor has already mentioned about 3-swab technique in her presentation. 3-swab technique we are following for pediatric patients. First, it is disinfected with alcohol swab. Secondly, with povidone iodine, and finally with alcohol swab. Povidone iodine is not left for longer duration, and Scrubbing should be done at least for 15 to 30 seconds. Drying is equally important. It should be allowed to dry at least for 30 seconds for chlorhexidine and 1 to 2 minutes for povidone iodine. For preterm babies, it is important that we avoid povidone iodine as well as chloroprep preparations because they are hypersensitivity risks, as well as with the povidone iodine, baby is at risk of getting hypothyroidism if it is not cleaned with, it is not wiped with alcohol swab as a last step. So we can use octinicept, or we can use lower concentration of chlorhexidine for skin disinfection. That's all.
Yeah, you're right. That's very important. How do we collect and what disinfectant we are using, and specifically taking care of preterm. Thank you for highlighting that. With the time constraint, I couldn't take all those things, but it's very important what you said. Thank you.
Right. So now, depending on the indication and the clinical scenario, one has decided that one should use antibiotics. So I would like Dr. Jyoti here again to tell us about the importance of antibiograms. And
yeah, I would like to share some slides. Dr. Monica also mentioned about the role of MIC values in terms of breakpoints. I would like to explain the same with one sample report. Just a
So,
minute.
Jyoti, while you are preparing your slide, do you release the MIC every time?
I'm searching my slides.
Yeah, before, I mean, if she's putting the slide, what I think about the early onset sepsis and the LP, what Dr. Javed was saying, I was saying the same thing. I mean, to re-emphasize, if the baby is clinically really looking infected and septic, then we do the LP in the early onset sepsis. It's known that the meningitis is not that thing, or the blood culture comes positive. But if the baby really clinically looks infected, and not just based on the perinatal risk factors, for those perinatal risk factors, if we start antibiotic, that's not the time when we do LP. But if the baby looks infected and septic, we really, irrespective of whether the blood culture is positive or not, we do LP, even in the early onset.
there's a comment by Dr. Ramnivas in chorioamnionitis said we use septic calculator, only start antibiotics if indicated by it. So I think that was one of the indications that you mentioned for straight away going ahead and using antibiotics.
But that's, this is
Yes,
that scoring, which is, we call it Kaiser permanent scoring. This is only for the 34 and above.
34 above,
full-term babies. This is for the mainly for full-term babies. So it doesn't apply in preterm babies. So it's a very limited value, but in full-term babies, you can use it.
Yeah, more than 34 weeker.
Dr. Jyoti, ready?
I think you have to give her that.
I'm not able to share my slides.
Because from me it has to go, then only she can put, no?
Dr.
So
Jyoti,
you
you
can
can
stop
explain
sharing.
it here.
Tawfiq,
Yeah, can you explain
you
just,
have to
Dr.
make
Jyoti,
her
about
as
the MIC?
a
Yeah,
presenter.
I would just explain that because I'm not able to share my slides.
You
Actually,
explain, Dr. Jyoti, you just explain whatever.
okay, it is difficult to explain, but I'll try to explain.
No, Tawfiq, you have to make make her presenter and not me, because I'm right now presenter and I can only
You have
share.
to.
It's okay. I'll try to
It's
explain.
not like that. She can, all the panelists can share.
Oh, okay. Okay.
Anyway, we can ask other questions till the slides are ready.
There's another question regarding CRP by Dr. Amit Suyal, saying that CRP more than 1 milligram per DL in sepsis screen, but most of the labs have their normal values cutoffs at 6 milligram per DL. How do you go about that?
You're right. It should be more than 5.
More than 5.
Yeah, not 1.
Yeah.
One is, I doubt. We take more than 5. Then, but we have to have with other.
No, so
We
that's
don't
why it is
consider.
like whether it
We
is
are not happy with CRP only, and it should
Yeah.
not be alone. taken.
alone CRP never.
Yeah.
And the other question is about the premature babies. Less than 30 weeks gestation should all be started on antibiotics.
No. I
No.
just
Send
gave one
septic screen.
examples, 3
No,
examples
no,
of
no,
preterm
no, not
babies
at
not
all.
to
No,
start
So I think
antibiotics.
this is the doctor's
No.
not written
She
his
told,
her name.
no, everybody agrees, no need.
No, no,
Unless
no.
there is something is there, regarding clinical, like the labs, like the
Yeah.
history, all these things you have to keep in mind. Then
Not
you
at
have
all.
to think.
Extremely low birth weight babies.
No,
Still no.
it will.
That's why I gave those, like,
But they will have, if the babies, I will tell you one thing, maybe many of them, they will get antibiotics because there will be something else with it. You will see, mother has got rupture of membrane, mother has UTI, mother was many vaginal examination. There, most of them, they will get it. But the idea which I told before, you must stop it after 36 hours. We applied this and it worked very well without any danger to the baby.
You have to stop
Okay.
it at earliest.
And I don't understand this, but I think the same doctor has written KP sepsis calculator is not valid for UAE. Why is that?
Why UAE?
Why UAE? Who told you why UAE? Why? We said not for the preterm babies.
No, it's not for preterm babies. It's for the more than 34 weeker.
Exactly. Okay. And should the healthcare staff in NICU undergo periodic checks, or do they undergo periodic checks of nasal swabs to check for pathogenic colonization? By Dr. Amit.
There is a periodic checks of the random checks of these staff, which is being done by our infection control people. Also, they are taking random swab checks of the areas of the NICU. That is being done, but not all the staff is nasal swabs is being done in our NICU.
Yeah, it is not recommended.
To add on, it is not recommended in
Not
normal
recommended.
circumstances, only if there is an outbreak.
Yeah.
Yes,
That only
yes,
we are
yes.
going to investigate. Staff needs to be screened for MRSA.
Yeah, in case outbreak, and especially then you have to do a root cause analysis, because I was an infection control committee chairperson of that one. So I was doing all those things. So as a part of the root cause analysis, then it needs a, like a surprise check, hand culture from hand, sinks and these things nowadays nobody allows environmental, but mainly hands and the nasal swabs.
I want to interrupt and ask one question, all panelists. Dr. Monica, was there any study, use of gloves, masks, not to use ring and other thing versus just washing the hands and going? Was there a study in the NICU?
Yeah, there are quite a few studies were there before, but now it is very old topic. Now it is a must, no jewelry. Jewelry must not be there. No neckties, no white coats. This should not be there. You wash your hands.
What about
because
gloves?
Gloves, I tell you, we have got two types of, precautions. One is called standard precaution. One is called contact precaution. If the standard precaution means you need not to wear the gloves if the baby is not infected, or if you are not touching the body fluids like saliva, mouth, stool, urine, like these things. But if a contact precaution, you have to wear the PPE complete, you have to mask, cap, you have to have gloves, you have to have gown, and you cannot enter the room of the baby if there is under contact precaution, like those who are multi-drug resistant organism, like MRSA or ESBL positive, or there is carbapenem resistant organism. In those cases, you must wear all these things. Otherwise, only standard precaution you are doing. Standard precaution means that we consider any patient who is admitted to hospital should be considered as infected unless you prove it. So that's why you must wash hand patient to patient when you go, and wear the gloves when you are touching body fluids. This is the standard.
So those WHO 5
yeah, those are
Five moments of hand hygiene.
Yeah, They
5
have to be
moments,
followed.
5 moments.
5
Yeah.
moments of the hand hygiene before
We
touching,
should
after touching, before and the thing of
aseptic procedure
contaminated.
after blood body fluid exposure and
Yeah.
after touching the patient
Yeah.
You must.
surrounding.
Even before gloves, you have to wash the hand or
Wash
have
the hand,
hand
yeah.
hygiene, and after the gloves also. When you remove the gloves, you have to again do it.
Dr. Monica, there is a question from Turkey by Dr. Aslan.
Yeah.
Regarding dual antibiotic in early onset sepsis, ampicillin, gentamicin, can we make it a monotherapy?
Yeah, we can make like penicillin. And also it depends on your antibiogram, what we are having in your unit. Because when I UK, because they were having an antibiogram and what is the bacteria, what they are having. So they were giving only augmentin. They never used augmentin for early onset sepsis, but that was what the bacteria was growing, and that was the sensitivity most of them were having. So, and some of the units are using only penicillin.
Although it is even
If-
by the leaflet of augmentin is mentioned not to be used in neonates because of the liver damage.
They were
and
using
cholestatic.
augmentin, and
there
because
is
of the antibiogram which they were having, and we in our unit are using MP and gentamicin. Some of them are using only penicillin.
See,
Yeah, that
whenever
most of the units they are using, Dr. Javi, just most of the units, even in Latifa, using MP Genta. But what's the doctor is asking, can we use a single? So it is okay to use a single.
see,
No,
we have.
if you want to use
Can I
only
answer the question?
ampicillin or only gentamicin, no. It will be like if you had an antibiogram which suggests that only the organism which you are growing over time is only to
So
amikacin
he's
or
saying about empirical, not.
regarding
empirical
empirical
only.
therapy.
For empirical only, your unit has to have the antibiogram, which what bacteria is growing and what cultures are growing, what is sensitive to it. So if that is showing any like only ampicillin or only gentamicin or only penicillin, then only you can use one. Otherwise, we cannot, because I mean, penicillin will be the only one which we can use single. What I
I would like to add on target organism in case of early onset sepsis are likely to be from maternal flora.
yeah,
Group B,
that's right.
Streptococcus, Listeria, or E. coli. So we would like to cover all the three. If we want to cover all the three, then we have to give combination of MP and Genta, because MP will cover your gram positive, but not gram negative. It is not that effective for gram negative. Susceptibility of ampicillin is very low for gram negative organisms, but because we want to cover both, so gentamicin has to be added.
Yeah.
I will add one thing. Now, ampicillin alone, I don't know whether anybody will use it, but we have got 3 different types of antibiotic uses. One is called empirical antibiotic use, one is therapeutic, one is prophylactic. Here we are using empirically. Empirically, you have to cover both of them, gram positive and gram negative. So that's why ampicillin, gentamicin is needed. You can use MP alone, but gentamicin, at any cost, you cannot use it, because within 3 days it will become resistant. So that is not, in newborn, we never use gentamicin, or I have never seen anywhere. But ampicillin, you
Khalil also
have
has written, sorry, I'm interrupting, gram-negative infections are nightmare. We should use 2 antibiotics. So any comments?
What?
I think
nightmare.
gram-negative is a nightmare and 2 antibiotics should be used.
Yes.
No, that's why we are saying MP and Genta. That's why we gave. This is what we are saying. For gram negative, we have to use gentamicin. But gentamicin alone, what he's saying is cause resistance. You cannot use
Within
alone
72 hours, it will be resistant. So must not be used.
which is very correct.
There's another comment regarding CSF. Dr. Javed, Dr. Joby Jacob has written that you said if blood culture is positive, what if the baby is septic and empirically started on antibiotics? Blood culture report will take at least 3 days. So any rationale for doing CSF
we
after
give the
3
dosage.
days?
The dosage which we antibiotic at that one we use, it is a septic dose, it's nearly meningitic dose. So we don't lose anything. At the time baby is covered with the empirical antibiotic, we must know our flora where we are, whether it is early onset or late onset. Now, for example, in Latifa Hospital, and I was there, the most common organism was Klebsiella and Staph aureus. Now I am in CMC Hospital. We have there that E. coli is the most common organism. And the first thing when I entered, I took out the data and the sensitivity of this organism. So that when you choose the antibiotic, you should know flora and you know which is the most sensitive antibiotic is there. So when we are using for we have already, for empirical treatment, we already given the patient as a dose of meningitic dose. So when the culture will come, or baby, other parameter will show whether baby is improving, baby is deteriorating the condition, other parameters, CBC, CRP, or the ProCal is showing what is, because that is the best thing for the follow-up of the treatment. So according to that, we'll decide. Each patient will be individually decided, but not as a routine.
That's why we said if the baby is really clinically looking very septic, infected from beginning, you can do LP from the beginning. But I mean, if the baby, you have a borderline baby, you wait till the blood culture comes positive and then you can do it. But just based on, as I said, we said that just based on the risk factors, we cannot. We have to look at clinically the baby.
One thing we have to keep in mind for all our attendees, those who are attending, when you are choosing an antibiotic, if they wrote sensitive, but it is 20% resistant, for example, 80% is sensitivity. So at that time, don't use those antibiotics. In newborn, we don't use bacteriostatics. We don't use those who have got the less sensitivity, for example, less than 80. It must be above 80. And it should go in hand with your flora. This you have to keep in mind while you are starting antibiotics.
Actually, my talk was not to start antibiotic, but now we are talking on.
Yeah.
But every aspect is important.
I know,
Not
I know. I'm just joking.
But when you,
I'm just joking.
You talk about zero antibiotic, but you did not talk about a zero antibiotic. You talk about zero antibiotic.
No, I didn't give antibiotic to so many babies. I gave example.
No, zero means NSC, zero. Anyhow, go ahead. Any other questions we have?
There is Dr. Khalaf Kergeri from Iraq. He's asking if a baby born with a mother has a premature rupture of membrane more than 24 hours and the baby admitted to NICU. So shall we collect CBC, CRP, blood culture immediately, or shall we wait after 18 hours?
Which scenario?
Yes.
PROM within 18 hours.
Premature rupture of membrane more than 24 hours.
Yeah.
And the baby admitted to NICU. So shall we collect the CBC, I mean the septic workup,
we told
or
about,
wait to 18 hours?
We see, before 6 hours, we don't get any response. You need to give time for the baby to give response. You're just collecting the blood and you're losing the blood. And, you know, especially this premature baby, you will have more blood loss and then you will give blood transfusion to these babies. So
we have to wait for 18
even
hours.
for these babies, as I told, umbilical cord is used by many of the centers now to take the culture. But the septic workup is to be done later on after minimum 6 hours.
It depends upon the history. For example, if the mother has got a fever, if she has got a foul smelling, for example, is amniotic fluid with rupture of membrane, because rupture membrane, we call it premature rupture when it is more than 12 hours. So, but it doesn't affect the baby, but every hour which is passing, it goes on increasing. And especially after 18 hours, it steeply goes up, the chance of infection. So this is first you have to see the history first and see the baby's clinical condition, then the other parameters, and then you think about the antibiotics. Most of the time they don't need.
No, the question is not for antibiotic. He's talking about when do we do the blood test? That is the question. Yeah, Dr. Diari?
Yeah, yes, exactly. To wait for 18 hours or immediately to
collect? Blood culture you have to send.
Blood
culture you have to send, but CRP you have to wait. CRP or other things you have to wait. Yeah. CBC might not be that you delayed, but blood culture you have to send it because you want the answer very quick back.
Yeah.
I have a question to Dr. Ajoti. Dr. Ajoti.
Yes.
You know, most of the neonatologists, they are sending a nasal swab. And it is coming, for example, Klebsiella pneumoniae positive. So do you release these reasons, these cultures, or you just wait for the, for example, MRSA? Because some neonatologists will start treatment of Klebsiella pneumoniae nasal swab.
No. We are not reporting Klebsiella pneumoniae in nasal swabs. We are getting nasal swabs for MRSA screening only. In those cases, we are reporting only MRSAs, not any other organism.
Okay, so it is clearly that you are not releasing, even if there is some other
No,
organism, it is
we
only
are
MRSA.
not
Although
even
we are
doing
PCR,
culture for Klebsiella pneumoniae. We are screening only for MRSA.
MRSA.
We are using culture media which grows only MRSAs,
MRSA.
not gram-negative organisms.
Yeah, only MRSA, that is PCR can be done immediately. You can get result in
PCR,
2
yes, we are
hours.
doing now PCR. Yes,
But
exactly.
in NICU, any person who's working there, he's not allowed to touch nose, ear, hair, eye. These things they are not allowed to touch. If they touch, they have to do the hand hygiene. Because many people will be colonized with the other than MRSA. So that is not be as a considered. So only they have to take the precaution. You have to break the chain. But that's it.
Along with that, Dr. Preeti Singh has written that in their center in US, the staff is not allowed to use nail paint, short nails, so all these precautions.
Of
Yeah,
course,
Yeah,
certainly.
it's very much needed.
Nail polish, not
Nail,
allowed any
see,
jewelry, not allowed bracelets, anything.
my
Not
nails, nothing.
Good. So, and she's mentioned that KP sepsis calculator almost always recommends to consider antibiotics if clinically symptomatic.
no, that adds to that one. Just go back to this one, you will see it. That will add, clinical condition will add to that one, whether it's clinically stable or not. When clinically not, at that time, it adds to the starting antibiotics.
So if you look at the score, what Dr. Javed said, if I had put first calculator, then 3 scenarios.
Yes.
Baby totally asymptomatic, equivocal, or clinically symptomatic.
Yes,
Depending
yes.
on that, they add on the score and then decide whether antibiotic to be given or not to be given.
Okay.
Doctor, okay.
Any other question now?
Yes, there's a question
Dr.
about
Monica.
late onset.
Yeah. Okay, go ahead,
Yeah,
Doctor.
go ahead. So there was a question about late onset sepsis, a combination of meropenem and vancomycin. Is that a rational antibiotic combination to use?
This question is to whom? Dr. Monica?
All of you.
Okay. I can tell you for that one, for the late onset sepsis, again, we come back to the same thing that you have to know your flora and their sensitivity. Meropenem C, WHO has done something very important. They have divided the antibiotics in 3 categories. That is called excess, then there is the watch group, and then reserve group. So excess group, which you use, they're all simple antibiotic like ampicillin, all those things which you have got, gentamicin, this thing, but other aminoglycoside that is under the watch group. So you try to not, if you do the audit on your antibiotic usage, you should make sure that your excess category should not be less than 50% of all of antibiotic usage. And your watch group, which you have got, for example, you have got tazocine, you have got other antibiotic which we are using, these are under watch group. But meropenem and other carbapenems and other colistin and all those things for the multi-result, that is under the reserve group. So these group should be not more than 20% watch group, and your reserve group should not be more than 2%. So this you have to see how you use it. Now we come back to the same scenario what he asked. Now, if it is nosocomial infection, late onset of infection is there, you have to see which flora at that time is going on. If you got on your ward at that time, you got a Klebsiella pneumoniae. So you know it possibly, the chance first is this, you have to cover that one. And then you start the antibiotic according to the what organism is at that time or most prevailing organism is there. So you cover that one. And then to do the septic workup, you continue those antibiotics till you get the blood culture negative or positive. And the other thing, as the baby's condition, how deteriorated or improving, that will show how to get that. Our setup is like this. We use in our setup any baby who becomes septic after 7 days, for example, or 5 days, after 3 days, this all late of onset sepsis. We start with them because we know its staph is the most common organism, flucloxacillin and tazocin, to cover the, for example, E. coli, to cover the Klebsiella, and to cover the staph. So later on, we de-escalate them after 48 hours or 36 hours when we get the cut. This is how we do it. Every center will be different. They should know their flora and their sensitivity.
Yes. So we have to know that what bacteria is growing, what kind of antibiotic sensitivity is there. It's true for early as well as late onset sepsis. Early it becomes much easier, as Dr. Jyoti also said, because the three bacteria we all know, which is more common causing, which is different for India, because in India early onset sepsis, Acinetobacter is also there. For us, it is Acinetobacter. GBS, we have Listeria, and we have E. coli.
When
But
poor
India,
hygiene,
you know,
hygiene
even
will be there.
so it depends. That's
I'm
why
sorry, I would like to interrupt. Viewers, they have written, let the speaker or complete the answer, then we go to other. Please, Dr. Monica, because they have written to me that questions are
oh,
half answered and interrupted.
he finished,
Yeah,
and I'm
please.
talking. He
Yeah,
finished,
please,
and
please,
I'm talking.
continue.
Yeah. He
Please,
finished,
please,
and
Dr.
I'm
Monica.
talking. What he's saying is correct, and I'm giving example of different countries having different thing, and for early onset sepsis, which bacteria in different countries may take place. So you have to target your antibiotic depending. What he said is the same thing. I'm just emphasizing on that.
Okay. Dr. Monica, Dr. Amit Suyal is asking about the prophylactic antifungals in extremely low birth weight babies.
No, earlier it came up as a big thing where they said that we need to prophylactic antifungal for a small baby, specifically if we have started them on antibiotic and we're putting them long line, but this is not, we are not practicing anymore. Some of the units, they say that if your fungal positivity is very high in your unit, and you have really proven it with your cultures, then only you start prophylactic antifungal in their units. But most of the 90% of the unit, maybe 99% of the units, they don't start prophylactic and antifungal. It came as a big thing, and everybody had started prophylactic antifungal in the extremely low birth weight units. What do you do, Dr. Javed? Do you start?
Our strategy was a little different. We started actually, who was there? Allah was there at the time, and we made at that time fungal was quite high. So we started oral mycostatin because we reviewed the whole literature. Oral mycostatin for extreme term babies, less than 1.5 kilogram, for 50,000 units, 6 hourly, and till the baby goes to full oral. And we saw sudden drop of our infections, Candida infections. Because Candida infection, when you have got a very busy unit, when the use of antibiotic is quite high, the Candida will grow. Once I remember, we have a outbreak of Klebsiella. We have 80 patients at the time, 80 patients and 40 ventilators going on at the hospital at the time. So at that time, we have an outbreak of ESBL positive Klebsiella, and we were compelled to use meropenem for a few patients. And we found out after nearly 4 days, all of them, they grew Candida. So when you use the broad spectrum antibiotic, a very strong antibiotic like meropenem, that is, we call it like say shot in the air, you do it. So we are compelled to do it because we don't want to lose the patient. Anybody maybe who was going setback at the preterm, we were starting. We said, but later on when we found out, most of them, they get Candida. But when this outbreak was over, then we stopped all this practice. So some centers, they gave twice a week, 3 milligram per kg. They gave is fluconazole. But because that has increased the resistance to fluconazole for the Candida infection, especially non-albicans Candida, they become resistant very fast. Now they are resistant to fluconazole. For that one, only amphotericin B is sensitive. So we were using only mycostatin because the colonization mainly in the GI tract and mouth is there. So we had got a good results. But here we don't use it because it's not very busy unit and not so many preterm babies.
Yeah. So
Okay. There's a question from Dr. Khalil about the empirical use of antibiotics in late onset sepsis. What do you choose? What combination?
he already answered, no, that it depends on the unit, it depends on your flora, it depends on the culture and sensitivity of your unit, and depending on that, you choose an antibiotic. So some of the units have more of gram-negative infection, then you will choose meropenem. Some of them have more of gram-positive, then you will choose vancomycin or whatever. It will depend on what kind of flora and bacteria we are growing. So we can't just for every unit say that choose this. And we have a strong antibiotic stewardship committee, and we have an infection control consultant and nurses. And if we use meropenem, which Dr. Javed said, these are the very high
Result.
yeah. So we have to really answer why we are using it. We cannot just use it and increase more drug resistance and
Yes.
then come to cholesterol, And then we are also now, I just had given talk in India about MDR in Neocon on MDR, which is different from this talk. MDR sepsis, what we do, where are we? That part is another talk itself, that when we deal with MDR monsters, what we are having, even cholesterol resistance have come up in some of the countries. So we don't want to go there, and that's why this talk came, zero antibiotic, and this means that less use of
Actually, for multi-drug resistance, they came up now for example, the meropenem salvage, strategy. They use a high dose of meropenem, although it is resistant. They use the colistin with it, and then, for example, ceftazidime is avibactam with beta-lactamase inhibitor, and they go on making the combination 3-4 antibiotic together. This is now the strategy which they are following.
Yeah, MDR is different topic.
There's a question from Dr. Raja about your recommendation on doing urine KOH and urine cultures for all preterms when you suspect late onset sepsis at the onset itself. Do you do it?
What you said, urine culture, what?
Urine culture and urine KOH in all late onset sepsis.
To rule out candida.
Do it right at the beginning, because they have high prevalence of candida wherever.
See, candida usually we don't expect unless candida, in what case we say candida was suspicious. If a baby who is a preterm, a baby who is in long time, babies on multiple antibiotics, broad spectrum, and now baby is not improving and their platelets are going down. Because we published a paper, 14 years study actually, candida in NSU Latif Hospital. So we found out this, all those babies, without that they will not get candida. Candida is not something that anybody, unless you give them antibiotics. This is because you balance this goes, the bacteria, normal flora, and the candida. When you suppress this one, candida grows. So if baby is not on antibiotics, you don't even consider candida. And candida, bad thing is you don't get blood culture positive because they have got affinity for the kidneys, and the urine is all the time positive. Fungal ball will be positive. You take the ultrasound, you will see the fungal balls in the pelvis of the kidneys, or urine culture will be positive, most of them. If no antibiotic, no anti-candida, antifungal.
Dr. Digari?
Yeah, Dr. Jyoti, I have a question to you. If you can elaborate more on the volume of blood for blood culture when the patient is 1 kg, 2 kg, 3 kg, because most of them, they are collecting, although Dr. Monica said 1 ml is enough. But in a 3 kg baby, 1 ml is not enough. It's not like 1 kg. So can you elaborate more on this, please?
Yeah, for pediatric age group, we recommend 1 to 2 ml of blood, because that is enough for positive cultures. But in case of neonates, we can accept up to 0.5 ml. If bacteremia is okay, then there are chances of getting positive. But if bacteremia is low, less than 10 to the power 4 CFU per ml, then chances of getting false negative are more. So for neonates, we should aim at 1 ml of blood, but for pediatric groups, or if patient's weight is more, like 3 kgs or all, if it is possible to get up to 2 ml, we should collect 2 ml. Minimum 0.5 ml for low birth weight babies.
Thank you. Dr. Monica, what's the role of antibiotic in suspected cases of neck? Dr. Monica.
So neck is a very, very like, I have seen like if you, first of all, diagnosis of neck itself is a very controversial thing, whether really it is a neck or it is just a feed intolerance. So we need to differentiate between that. And sometimes I have seen, the neck mimics are also there, like the CMV infections may present like neck. Or sometimes surgical, I have seen one case, like suddenly when the deterioration happens, I have seen the volvulus and thing may present like neck. So we need to differentiate all those. We are sure it's neck, then we have to start antibiotic for sure. And we have to cover from gram negative, and even we have to add metronidazole for the that bacteria. But that's only when we have really diagnosed it as a neck. But because most of the time, just feed on tolerance and we say it is neck and we start antibiotic, that's not right. One vomiting and we say it is neck, that's not right. Yeah.
So what we understand that the patients in the NICU, they are colonized. Most of them, when they are staying long time and on antibiotic, they are colonized with. And you mentioned that no prophylactic antibiotic for clean surgery. I do understand that, for example, a patient which go for VP shunt, which is implantable device, and the CSF, which is a clean, let's say, container, it doesn't need a prophylactic antibiotic?
It needs, if you remember, Dr.
That
Diarya,
one would be needing an antibiotic. I just gave example of like, the case like if just because it meningomyelocele is open, you start antibiotic before this. Like we are not doing surgery immediately, right? So the main thing is that you should be putting it, covering it and keeping it clean and not allowing infection to go in till the surgery occurs. That was the study of those meningomyelocele patients which was done. That is what I was emphasizing on.
Dr. Javid, any input?
regarding, now there are two questions together. Now for the necrotizing enterocolitis, many people they consider it is one of the infectious disease. So you have to have gram negative covered, anaerobes to be covered. There's no need for gram positive because there is no gram positive which can give rise to any this types of infection. This is almost always this is gram negative. So the best possible combination will be tazocin and one of the aminoglycosides, and there's no need for metronidazole because nowadays nobody is using it because most of the antibiotics like tazocin is extremely good and anti-anaerobic. So it is automatically it is covered. So we don't need to expose the baby to such a strong type of thing, this thing. So antibiotic is needed. You can stop at any time if the culture remain negative. We don't treat colonization. This we have to keep in mind. We should know our baby, those who are colonized or this thing, anything. So when the patient is you, you know the status of the baby, but antibiotics is a must.
So zero antibiotic in ICU is not going to help.
See, zero is not possible. I was discussing Dr. Diarya Sam in the morning, we were in the conference. Zero is not, it can be a dream, but it will never be possible. We can decrease it with antibiotic stewardship program, which has been started all over and everybody is talking about antibiotic stewardship program. We started in Latifa Hospital from 2011 and we were the first to start Latifa Hospital Antibiotic Stewardship Committee and I was the chairperson of that one. And we decrease the antibiotic usage and we presented for JCI accreditation, all these.
You're mute, Dr. Javid.
Sorry?
You're mute.
No, we can hear him.
Oh, no, he's not mute.
We can hear him.
Oh, no, he's not mute. We can hear him.
Yeah. So that, for the use of antibiotics should be cut down. But it is impossible to age this. It can be dream or it can be something. something.
Is there any
main thing about this zero dream or reality is that to give cases where you should not be giving, and I have seen its use being used on those cases where I said it is not recommended to be used, and that's the whole
should not be used.
That is the whole emphasis when we talk about it.
Yes.
And second emphasis, what Dr. Javed said, how to reduce infection by itself, how to talk about right use of antibiotic, the right dose of the antibiotic, and right duration of the antibiotic, and when we can stop, please stop the antibiotic, and when can we stop? Because I have seen antibiotic once started keeps on going for 5, 7, 10 days.
We never use it.
No, so those things these are the main emphasis which has to go loud and clear, that where we can not give antibiotic, where we can stop the antibiotic early, where we should not be using very broad spectrum antibiotic, and where we how do we judge whether clinically baby is infected or not infected. That's the whole thing.
Right. So,
and then the mimics, the mimics is very important. Like, IVH, baby deteriorates because of the IVH, baby deteriorated because of the PDA, baby deteriorated because of, BPD. So
you have to rule out all.
Those babies don't need antibiotic,
Oh, no, of course, which is not infective. Who will use it?
Yeah.
Sure. So, Dr. Jyoti, my question to you
means infection. This is what should.
Okay.
Yes, doctor.
Point well taken. So we talk about CORTI, we talk about ventilator-associated pneumonia. So what is the role of the infection control bundles to be followed, the auditing to be done? Who does it? How important do you think it is? And also, are NICUs having some kind of grading depending upon their, antibiotic usage rate? This is to Dr. Monica.
No, we definitely, the use of bundles have come as a big thing for our babies, and the use is really important to take care of. Bundle means putting multiple things in one, so that we are able to. Everybody knows that these are the things which will take care of this particular thing. So that's why we have come up as Clepsy bundle, where we start from the time of insertion to how do we keep, and then it's when to while we are removing. So 3 places this Clepsy bundle will takes care of. So this will take care of the long line induced infections. So I mean, it's a big topic by itself. If I elaborate about what is Clepsy bundle would include, it's a big topic by itself. But I'm
so
just
that it is important.
Yeah. So then same is the ventilation associated pneumonia bundle, that first of all, don't intubate if baby doesn't require intubation. That is the first thing which you will do. And then secondly, how do you put should be done or not done? What do you do with oral secretion? Putting oral, colostrum in the baby's mouth, giving mother's own milk. How do you keep the ventilator tubing so that the thing should not go back to the secretion should not go back to the baby. So these all will come as a VAP bundle. Similarly, the importance of a nutrition bundle is important, because that itself takes care of infection. If we are giving mother's own milk, we are trying to create express the breast milk, and have lactational consultants in our units. Start antenatal. It will start from the antenatal classes, where we give emphasis on the breastfeeding. And here, unfortunately, we don't have milk banks. But there are places where milk banks, and believe it or not, the mother milk decreases the infection and use of antibiotics a lot. and it is it is to be taken up really seriously, that mother's own milk has to be given, and no other milk. So that emphasis is important. And then antibiotic stewardship program has not to be done only by one person. It is the full team is there looking into it, where infection control nurse of the unit, and then we keep one nurse as a fly, fly on the wall. So no one knows which is this nurse, which is looking into hand hygiene and into whether these bundles are taken
Being followed.
yeah or not. And no one knows, not even I know who is the nurse, which really helps in not to put blame on anybody, but to make sure that all these whatever bundles and hand hygiene things are put into place are really taken care of properly. And then we also involve outside and team, like how we have Dr. Jyoti here, so we have microbiology, microbiologist, pharmacist, infection control consultant, infection control nurse who is other than the NICU nurse, and then we have in-house infection control nurse and the fly this thing. So all these people together are running the antibiotic stewardship program, and also they are looking into these bundles. And then we have audit, which is very important. The audit has to be done to know where we are lacking and where we have done thing. We should have in our NICU, we should have a board where every day we are writing, like, how many are getting mother's own milk, how many are doing kangaroo mother care, how many this in bundles are being followed, and that is to be so that and then we weekly sit and talk about it, and monthly we do the audit about these. Anything? Yeah, this is important, and audit is not for blaming purposes. It is for the purpose to improve our unit, and everybody should be involved in that with no blame game.
Right. Now, quickly, there is a question which has come up 3 times to do with vaccination-induced rise in procalcitonin, confusion with sepsis. Can we wait? Because sometimes on day 45, while the baby might still be there in the hospital, gets the vaccination and even the initial vaccination. So what is your take on it, Dr. Javed?
See, vaccination usually is not given in NICU, unless baby is 2 months old. And at that time, baby is sick. First thing is, baby has to be sick, then you talk about the procalcitonin. If baby is stable, then baby will get vaccination. Very rarely, if baby stays more than 2 months, 3 months, at that time it will need. So if the baby is getting vaccination, it means he is not sick. If he is not sick, there is no need for any procalcitonin to be done. That is in case when you are suspecting infection. If suspecting infection, you will not give vaccination. So it doesn't go together. So there is nothing to worry about.
One point I would like to add, polio and rota is recommended when the patient is discharged, going home, to be given, irrespective of the age. Sometimes premature baby may stay there 1 month. Never give in the NICU or hospital live vaccine like polio and rota.
Yes.
So,
Live
but
vaccine.
Dr.
BCG is not given. At that time, oral polio vaccine was there. That's not given. Any live vaccination cannot be given when the patient is there. Patient should be just at the door when he's going. We give, for example, BCG if necessary.
But
That's
we are
it.
giving
He's right, doctor.
activated polio, Doctor.
No, it's not there. That's oral
Dora.
finish now. Yeah, I know it.
You're
That's
not giving oral.
Yes, that is gone.
I
Yeah.
think in India it is now past 12:30.
Yes, they are sleeping now. So,
Dr. Kalpana, if more questions are there, quickly we can.
No, just the last
have a-
one about the use of probiotics in neonates. Does that have anything to do with reduction of the antibiotic usage in your units? Is it, first of all, recommended? What is the role of probiotics? Dr. Monica?
This was a very
I
controversial.
will mention about this thing that when this L03 was discovered, of course, by Dr. German scientist author, it has been shown it has an antibiotic in itself, rotarin, which prevents the infection. That by nowadays comes in as a biograph. That has antibiotic in itself, and it prevents infection. And it has been found in newborn. It prevents infection also.
So I actually for the it's a very controversial topic, and every unit is different. Not only unit the countries are divided in the use of probiotics. Specifically, we talk about using them to prevent neck and infection, sepsis. So, and our main target for preventing neck and sepsis is our preterm babies. So when you look into the data, less than 28 weeker, most of the studies they have not, shown. So if you see US and UK, they don't use probiotic for prevention of neck in the preterm babies. But if you look at Australia, they have done a lot of studies, and their meta-analysis shows benefit of using probiotic to reduce the neck. I use Reuteri, and actually when you it's all these studies are so done heterogeneously. The babies which are chosen are so different. The time when you started the probiotic is so different. The type of probiotic chosen is so different. The doses of the probiotic which were given were so different in these studies that you cannot. This is like orange and comparing orange to apples. Those studies are like that. So if you look at the meta-analysis, some of them, they have shown two probiotic, Reuteri and the lactobacillus, their combination have been effective for reducing the neck. And I use Reuteri in my unit. The thing is that the right dose and the right time, because what is happening is we are dealing with dysbiosis, which is causing the problem. So if we are not starting the probiotic early on, already the dysbiosis thing starts. So if you start this probiotic later, and that's why I'm saying, when did you start? Which dose did you start? Which probiotic you used? That will give the different scenario. And this can be in I think UAE itself, when we talked, and actually we were planning to do one survey in UAE and India about the use of probiotic in different units, which we could not do because of the logistics. But when I talk to my colleagues here, some of them are using and some of them are not using. So I think 50% of them are using and 50% of them are not using. But definitely 22, 23 weeker, 24 weeker, there are not much studies which can say safety of the use of the probiotics. And these are the babies who will be having more chances of neck. So we don't know. What do you say, Dr. Javed? You're
We
using
don't use it. It's a controversial in preterm baby. We don't use it. When they are discharged, maybe in some cases we might use it. But
that's
not
what I
as
said.
yes.
Okay. So I think we are done with most of the questions here. Just quickly, each of the speakers' final, what message would you like to give? Dr. Jyoti didn't get to speak much, or explain the part that you wanted to explain. So just let us know your views from. Are the clinicians training you? Are they with you? Do they take you along in these decisions? What would you expect from us?
Yes. I would like to emphasize on good antimicrobial practices. Doctor has already mentioned about these things. Antibiotics are not at all recommended for viral infections. Most of the respiratory infections are viral infections, so there is no role of antibiotics in viral infections. Second thing is colonization and contamination doesn't need any treatment with antibiotics. We should choose narrow spectrum antibiotics whenever possible, and it should be given for shortest period. Broad spectrum antibiotics should be reserved only for severe cases and suspected MDROs. Dr. Javed and Dr. Monica, both of them have talked about restricted antibiotics. We do have restricted antibiotic list in our hospital. In fact, most of the hospitals are having this list, which includes antibiotics like carbapenems, ceftazidime, avibactam, ceftolozane, tazobactam, vancomycin. So these drugs are not to be prescribed. Pre-authorization is must for these restricted antibiotics. So they should be prescribed only after consultation with the antibiotic stewardship team. Another thing is the 48 hours timeout, which has already been discussed in length, so I'll not touch on this. It should be discontinued, de-escalated or escalated based on clinical response, biomarkers, and culture sensitivity reports. We have already mentioned that once the antibiotic are started, sometimes there is no follow-up for that. Review is very important at 48 to 72 hours. Antibiotic prescription is more or less like a habit. Once we start it, we are reluctant to withdraw before 5 or 7 days. But we should change our habits now. We should get confident based on repeated reminders or evidence-based studies are there which ensure better outcomes by reducing duration of antibiotic therapy. Standardized policies should be there on the management infections so that we can follow these policies at a central level, like national policies should be there. We have national policies on UTI. Similarly, we should have national policies on treatment of respiratory tract infections and other common infections like sepsis. So this will go a long way to combat antimicrobial resistance.
Thank you, Dr. Jyoti.
Thank you.
Dr. Javed.
I think Jyoti was telling quite good things. When you choose an antibiotic, first know your flora, know the sensitivity of that one. When especially empirical antibiotic you're starting, always choose narrow spectrum. Better not to take the broad spectrum, which will cover gram-negative, gram-positive, this thing. It is like jack of all, a master of none. So in narrow spectrum, will the least chance of resistance will happen. You can choose 2 antibiotics, one for gram-negative and one for positive, and that will make much better response as compared to, for example, you put him in Verapamil, which will cover everything. So this is, I think, and it has to be stopped within 36 hours according to our guidelines which we have. If the babies remain stable, if clinically stable first thing, and then if all the labs are normal, and if the baby's blood culture is negative, we stop the antibiotic 36 hours. So this, I think, we have to follow. Thank you.
And Dr. Monica.
Yeah, so they have already enumerated, but don't give antibiotic if it is not required. And some of the patients don't even need septic workup, where, when you do the septic workup and you get something here, there, and you start the antibiotics. You should have an antibiotic stewardship program in your hospital, and you should follow that very strictly. I would still emphasize on the bundle care, because that's very important for having even the cannula bundle care, CLAPSI bundle care, BAP bundle care, nutrition bundle care. It's really important. And as Dr. Javed said, that please, if you started the antibiotic, stop it at the earliest. And as I already mentioned, specifically for the late onset sepsis, and you're thinking about when you've started a very high, like meropenem or cholesterol or something like that, those kind of bugs will grow within 24 hours. So you don't have to wait for 48 hours. 24 to 36 hours would be good enough. If they did not grow, then please de-escalate the antibiotic or stop your antibiotics.
Right. I think there's a comment from Dr. Preeti Singh about the probiotic use in USA. There was a mortality in a preterm baby. FDA issued a warning last year. That. So we are still waiting for a further data on this topic.
That was just a probiotic which was not properly, kept.
Processed, maybe manufactured.
That got contaminated. So that's a different story. Yeah.
was withdrawn.
I
The
said
bag
USA is
withdrawn.
not using, but it's not just because of that, but it's like they're, yeah.
You
So,
should be careful in extreme
yeah,
preterm babies because anything their
yeah.
defense mechanism is poor, so they can have anything.
I would give
think
example. I would give example of the best. Before we finish, the best outcome country of these premature babies, 22, 23 weeker, which are born, which are have lowest mortality and morbidity. That is Japan. And when I met these Japanese consultants, I'm not saying because of this the baby saved. There are multiple things because of which the babies are saved. But they were using probiotics since many years. And what they were doing, they were every day they were seeing the flora of the baby stool. And then depending on what's happening to the change in the flora, they were taking the action. And their neck rate is very low. They are not putting umbilical lines. They are putting only PICC lines in these small babies. They have multiple other things, but this was one of the things that they were using probiotic. And they were seeing the flora. And the major thing was all consultant neonatologists were there 24/7 present in the NICU because, you know, the time for taking action when important. Yeah.
Good.
right. There is a query about the availability of this talk online. So to let you know that once finalized, it will be there on our social platforms. Like, subscribe, and share. So yeah, as the trend is nowadays. And with that, Dr. Saurabh, over to you.
Thank you very much. Before concluding, I would like to mention that lactobacillus rotary is the largest investigated. I mean, we have a lot of studies on that. Company has done studies on premature babies, but they don't recommend the use in premature baby. Now, two things Dr. Javed mentioned about gloves. I would like to mention something interesting. Halstead is the father of surgery, Dr. Diari. When he was working in his unit, there was one nurse who got severe dermatitis. He invented the gloves not for the prevention of infection, to protect her hands of that. This caused after one year they married and she left the unit and she went to the home of Dr. Halstead, and this is the history of how gloves came. I have mentioned this in other forums. You mentioned about cesarean, since we have a lot of audience. It is written in dictionary, probably Caesar was born through this session. No, it is not there. Before Julius Caesar, they used to they bury the mother and child. After Julius Caesar, the law came, if the mother dies, if a child alive or dead, open the abdomen, take out the baby. If baby is alive, well and good. This section under the Julius Caesar called Caesarean section.
Yes.
It is called in French Law de Caesar. So it is not that Caesar was born through this section. No.
Yes.
It is written in the dictionaries and all. So if you want, I can give reference. Thank you very much, Dr. Monica, for this excellent presentation, discussion, Dr. Javed. This was first time we had the meeting with you. Really, I learned many things. Inshallah, in future, we'll invite you again. Dr. Jyoti for excellent comment, Dr. Diari, Dr. Kalpana, Dr. Tawfiq for sponsoring, and all viewers staying away with us. We had more than 600, I think, viewers. Tawfiq will give us the number. And I would like to thank all the viewers from especially other countries, India, staying away with us. Thank you very much and good night. See you in our other webinars.
Thank you,
very much.
everybody.
Thank you,
Thank you very
everybody.
much.
Good night,
Everybody.
everyone.
So it's actually learning. When we present, we learn, and with discussion, we learn more. And different practices, which is always a problem everywhere. It's not a problem, means different practices because of the different that we come to know. And it's a good learning platform. Thank you, everybody. Thank you, Dr. Javed, for your inputs.
Thank you very much and
Thank
good
you,
night.
everyone.
Thank you.
Good night.
Good night.